So basically, the classification is used to navigate the explorers. And in olden times, stars and constellations were helpful for guiding the sea navigators. In today's day and age, the GPS and AI-based maps are helping us to navigate. Hence, the classification systems is basically a pre-op and intra-op GPS for a surgeon. So this classifying knee varus deformity, a new practical approach, this work was undertaken by us a couple of years back, and it is still going on. And the essence of it is going to be discussed today over here. So varus deformity of knee, by definition, as per this article quoted, is medial coronal plane malalignment, also known as a varus malalignment. The natural history of this varus disease goes back to this article quoted by Pont and et al., which has asymmetric joint loading, which leads to a medial compartment asymmetric degenerative changes, which leads to osteophyte formation at the medial compartment, followed by tibial osteophyte, femoral osteophytes, then metaphyseal beaking, femorotibial subluxation, and later on stress fractures. So this made us think following questions: how these radiographic features of disease severity correlate with the degree of varus knee deformity. Next, whether more severe radiographic features are always found in more severely varus knees, and whether milder radiographic features are always present in knees with lower degree of varus deformity. Further, we also had to think about why severe varus deformity is sometimes observed in the absence of impressive signs of intra-articular wear, and why advanced medial osteoarthritis sometimes present with a low degree of varus alignment. So this paper by Pont and Parvezi, which described a new classification system published in Journal of Arthroplasty, gave us a classification according to the location. So type IA is intra-articular diaphyseal, which had two components, reducible and fixed. Type M is metaphyseal, which is 5 centimeters within the joint line at both the ends, femoral and tibial. Type D is the diaphyseal, that is more than 5 centimeters away from the joint line, which had following components: diaphyseal tibial, diaphyseal femoral, and diaphyseal tibial and femoral level. From taking a cue from this point, we progressed further, and what we did was to grade the varus deformity as per the natural progression of osteoarthritis, stage the deformity as per the hip, knee, ankle axis, location of the deformity to ascertain whether the deformity is intra-articular or extra-articular. And all this thing was carried out just keeping in mind to aid the surgeon in decision making before and during the knee arthroplasty surgery. So the aim of the study was to identify the radiographic features, correlate these features with severity of the varus deformity and the degree of coronal deformity to determine the location of varus disease. So the followed consecutive radiograph of 100 knees were studied, and for each patient the severity of coronal plane deformity expressed in HKA was calculated. The primary location of the apex of the deformity was found out, and presence or absence of 10 different radiographic features of osteoarthritis were noted. So according to this figure, we classified this into three grades, that is grade A, grade B, and grade C. Grade A had following radiographic features: joint space narrowing, tibial osteophyte, and femoral osteophyte. Grade B had, along with grade A, it had metaphyseal bump, tibial defect, femoral flattening or femoral defect. And grade C, along with grade A, B, it had subluxation, stress fractures, tibial diaphyseal remodeling, and fibular remodeling. So these are the radiographic pictures which shows grade A, grade B, and grade C. So the next part was to calculate the stages according to the hip, knee, ankle axis. And stage 1 was varus alignment up to 10 degrees, stage 2 from 10 to 20 degrees, and stage 3 more than 20 degrees of varus alignment. So the location of the varus deformity was calculated. The deformities assessed as extra-articular were those that had an apex more than 7 centimeters beyond the tibial joint line and 3 centimeters beyond the femoral joint line. And why this 7 and 3 is because the anatomical reference point for the medial collateral ligament insertion. The extraarticular apex location was determined by identifying the center of rotation of angulation. So if the apex of the deformity was extraarticular, the knee was considered to have a constitutional varus. If LDFA, that is lateral distal femoral angle, is more than 90 degrees, the deformity is in femur. If the medial proximal tibial angle is less than 87 degrees, the deformity is in tibia. A convergence angle of more than 2 degrees signified medial cartilage loss with tightening of medial structures and or opening of the lateral side as a contributor to the varus deformity. In order to eliminate the bias, we did following things. The angular measurements were made by 2 different orthopedic surgeons, one by a consultant and one by a final year trainee, and it was repeated after an interval of 1 week. The inter-observer reliability was calculated with the use of kappa statistics. These measurements were performed manually with a scanogram by 2 independent observers, and the inter-observer accuracy was tested by repeating the same angle measurement 10 times and was 1 degree for described measurement. So the results were mean age in our sample size was around 67.6 years plus or minus 8.5 years. Female had 62, like there were 62 knees which comprised of female patients and 38 were of male patients. A mean varus deformity was 11 degrees plus or minus 6.6 degrees, corresponding to the hip and knee ankle axis of 169 degrees. For the stages and location of varus deformity, out of 100 knees, 27 had stage 1, 50 had stage 2 varus, and 23 had stage 3 varus. There were 86 cases of intraarticular deformity and 14 cases of extraarticular deformity. The correlation between the stages and grades of varus deformity, we found a correlation coefficient of 0.668. That was a strong correlation between the stage and grade of varus deformity. All patients in this cohort were independently classified by 2 different observers. There was a strong positive correlation with R value of 0.887 and the P value calculated from Pearson's coefficient was 0.00001. So the major highlights of this study were, for most of the knees, higher degree of varus, that is stage 3, had worse radiographic features of deformity, that is grade C. Some knees with lesser degrees of varus also had worse radiographic features of deformity, with 13 knees in stage 1, 38 knees in stage 2 having grade C deformity. A small subset of patients with stage 3 varus had milder radiographic features of deformity, that is grade A and grade B, as a result of deformity being extraarticular. Usually the knees with higher stage of deformity will also have a higher grade of osteoarthritis. This correlation was shown to be present in the study, with grade C deformity observed more frequently amongst the knees with varus more than 20 degrees. So the similar findings were echoed in the literature with following 3 papers which we found. That is, one is bone morphotypes of varus and valgus knees by Heinpont and et al. Stephen Howell's cruciate retaining implant, which was published in Knee Journal, and tibial intramedullary canal axis and its influence on intramedullary alignment system entry points in Koreans. Points to ponder at this stage were, the surgeon might be alerted earlier to the condition that requires an alternate surgical approach when he considers both grading and staging. And patients might also have more soft tissue laxity as a result of compensatory unloading mechanism and more external rotation, leading to an underestimation of varus measurement. So why this study is special? Because this study is the first to our knowledge to demonstrate that the degree of varus, that is stage, is correlated with the severity of radiographic deformity in the knees with varus OA. And the interaction between the varus stage and the osteoarthritis grade seem to differ between the knees with intra versus extraarticular deformities. This study also had some limitations. First is relative small sample size. Further, the coronal deformity was often the result of dynamic interplay between the soft tissues and osseous anatomy, a factor that is often missed on static radiographic studies. And CT scan was not performed to differentiate individual rotational alignment of tibia and femur. So the take-home message is, notable angular deformity in the absence of grade C radiographic features should alert the surgeon to a potential extraarticular deformity or constitutional varus. And the grading of osteoarthritis can help the surgeon to better understand the extent of intra-articular disease, and the potential complexity of epiphyseal reconstruction during total knee arthroplasty. The constitutional varus and the stage grade disparity may be considered signs of morphological outliers. Advanced preoperative planning and the patient-specific preoperative approach and the implant selection may make difference in patients with varus deformity of this knee. So this work was published in JBJS reviews last year in October 2021. And these were the contributors: Dr. Vaibhav Bagaria, myself, Dr. Omkar Sadigale, Dipit Sahu, Dr. Jawad Parvizi, and Emmanuel Heinpont. And this was rated as top 20 most read article of 2020 JBJS reviews. And it wouldn't have been possible without you all. I would like to thank each and every one of us. Thank you so much.